Hey everyone, welcome back. We are jumping right into part 54 of our 100-part CPC exam series. Today's explainer is all about taking those dense textbook coding guidelines and turning them into real-world logic. We're tackling integumentary system case studies. So, if you've ever felt completely tripped up by skin, subcutaneous tissue, or those tricky wound repair scenarios, you're in the exact right place.
Real quick, before we start crunching the CPT math, I need you to do a huge favor for me. Make sure to like, share, and subscribe to Decode Healthcare with Harshal. It literally keeps this channel going and helps us build these structured explainers for you.
All right, here is our roadmap. Today, we're conquering lesion excisions, wound repairs, tissue transfers, breast procedures, and wrapping it all up with exam pitfalls. Let's go.
Starting off with case study 1, lesion excisions.
Okay, picture this. A patient comes into your clinic, and the surgeon excises a 1.5 centimeter malignant lesion right off their face, taking 0.5 centimeter margins on each side. But wait, in that exact same session, they also remove a 1.0 centimeter benign lesion from the arm with 0.2 centimeter margins. Now, how do we code this? Well, you've got to use the golden rule you see here. You can't just look at the lesion size and call it a day. You have to take that lesion diameter and add the margin. But here's the kicker, you have to add it twice. Why? Because that margin exists on both sides of the lesion.
Let's actually walk through the math. For the face, we take that 1.5 centimeter lesion, add 0.5 for one side, and add another 0.5 for the other side. Boom! That's a 2.5 centimeter total excise diameter. And that 2.5 is the exact number that drives our malignant code selection. Now, doing the same for the arm, it's 1.0 plus 0.2 plus 0.2, which gives us a 1.4 centimeter total for the benign code. See? It's like a puzzle, but the math is pretty straightforward once you know the rule.
But here's the thing. Math alone is not going to finish the job for you. You absolutely 100% must have the pathology report to confirm if that lesion is benign or malignant. Why? Because they live in completely different CPT code families. If you just guess without that path report, well, that's a fast track to massive compliance issues or totally denied claims. Oh, and remember, every single lesion excision gets reported separately.
Moving right along to case study 2, wound repairs and closure rules.
So let's say a patient comes in with 3 distinct lacerations. We've got a 2.0 centimeter simple repair on the scalp, a 3.5 centimeter simple repair also on the scalp, and a 4.0 centimeter intermediate repair on the forearm. How in the world do we code this without unbundling incorrectly? We follow the 3 strict steps laid out right here. Step 1, group them by classification. Simple goes with simple, intermediate with intermediate. Step 2, group by anatomical area based on CPT guidelines. So here, the 2 scalp repairs group together. And finally, step 3, sum the lengths of those matching groups. Since the forearm repair is an intermediate classification in a totally different anatomical zone, it just stands completely on its own.
Following those steps, we just add the 2.0 centimeter and 3.5 centimeter simple scalp repairs, and that gives us a neat total of 5.5 centimeters. You report a single CPT code for a 5.5 centimeter simple scalp repair right alongside your separate code for the intermediate forearm repair. It's actually beautifully logical when you break it down like that, right?
Okay, on to case study 3, tissue transfers versus grafts. Let's say your surgeon excises a 3.0 centimeter skin carcinoma on a patient's cheek and then reconstructs the defect using a Z-plasty. Now listen closely because this is a massive exam trap. A Z-plasty is an adjacent tissue transfer, or ATT, and the absolute critical rule here is that the excision of the lesion is completely included in the primary tissue transfer code. Do not, under any circumstances, report the lesion excision separately when you are coding an adjacent tissue transfer.
Now let's contrast that with free skin grafts, your split thickness or full thickness grafts. With these free skin grafts, the excision of the lesion actually is coded separately from the graft itself. So, to recap, adjacent transfers, bundled. Free skin grafts, separate. I promise you, knowing this distinction is going to save you major headaches on exam day.
Next up, case study 4, breast procedures. With breast procedures, the specific surgical technique fundamentally changes your code. Let's pause on this for a second because the differences are subtle but super important. For instance, a fine needle aspiration is vastly different from a core needle biopsy. And hey, if that core biopsy uses ultrasound guidance, you have to check if the imaging is bundled into the surgical code or not. The exact type of mastectomy matters immensely too. A modified radical mastectomy automatically includes the axillary lymph node dissection, whereas a simple or complete mastectomy just doesn't. You've got to read the operative notes closely.
All right, let's wrap up with Section 5, Key CPC Exam Pitfalls for Integumentary Coding.
Pitfall number 1. Do not mix up surgical debridement with active wound care. True surgical debridement codes are strictly driven by the depth of the tissue removed. We're talking skin, muscle, or bone, and the total square centimeters treated. Active wound care, on the other hand, is non-surgical management. It lives in a completely different code series entirely.
Pitfall number 2. Vocabulary matters. Shaving is a tangential removal. Excision, however, requires full-thickness removal completely through the dermis. And destruction? That means the tissue was ablated or destroyed, usually using a laser or chemicals. Remember, it's the surgeon's specific technique that dictates your code family, not just the fact that a lesion was removed.
All right, here is your visual cheat sheet. Seriously, take a screenshot of this right now. I'll give you a second. Got it? Okay, great. This beautifully synthesizes all the high-yield if-then logic we just broke down. Doing an excision? Use the margin formula. Tissue transfer? Bundle the excision. Free skin graft? Code the excision separately. Repairing wounds? Sum them up by classification and anatomical site. It's the whole shebang right there.
Just like that, you have completely leveled up your integumentary coding skills. But ask yourself this. In the real world of medical coding, a single millimeter or a misread margin can literally change a patient's entire surgical narrative and a hospital's bottom line. Are you ready to be the expert who gets it exactly right every single time? Well, coming up next in Part 55, we are taking a deep dive into the musculoskeletal system. We're talking fractures, dislocations, arthroscopy, and joint injections. You definitely won't want to miss it. See you in the next explainer.